this video, we will discuss about addictive drugs. So there are plenty of addictive drugs available, but we will mainly discuss about two drugs. One, opioids, and second, alcohols. We will start the discussion from the opioids.
Now, opioids are the substances which are obtained from opium. Opium is the crude extract of a plant called poppy plant. Scientific name is Papaver somniferum. So the crude extract of this plant is called opium, and the drugs which are present in the opium, they are called as opiates. The drugs which are present in opium are called opiates. The major opiate is morphine. Now, as we are concerned with the function, even if a drug is not obtained from opium, but it is working like morphine, those drugs are called opioids. The difference between opioid and opiate is, opiate are the natural substances which are present in opium, whereas opioids are all opiate-like substances. That means all morphine-like substances are called opioids. But for a substance to be morphine-like, first we need to know what morphine does.
Morphine acts on three main receptors: mu, kappa, and delta. We know morphine is a powerful analgesic drug. So all these receptors, they mediate analgesia. That means stimulation of mu receptor also called analgesia. Stimulation of kappa also cause analgesia. Delta also cause analgesia. Now, apart from analgesia, mu receptors have many more actions, whereas kappa receptor has one more action which you need to remember, that is called as dysphoria. That means if a drug stimulates kappa receptor mainly, it can cause dysphoria, and this dysphoria can manifest as hallucinations. So CNS side effects, bad dreams, hallucinations, etc., they are manifestations of dysphoria. Now, more important are mu receptors. So you should know the important actions of mu receptors, and these actions we remember as sacrum. Important actions of mu receptors are sacrum. S for sedation, A for analgesia, C for constipation, R for respiratory depression, U for euphoria, and M for meiosis. So we'll discuss these actions one by one in detail. The first action is sedation. So morphine-like drugs, they stimulate mu receptor which cause sedation. And if we stimulate mu receptor more than required, what will happen? Yes, the person will go to coma. So in morphine poisoning, the patient usually present in comatose state because mu receptor depress the brain. Okay. Then A for analgesia. We know morphine is a very powerful analgesic drug. It is indicated in very severe pains like cancer pain, pain of myocardial infarction. So morphine is very good analgesic drug. It can be used to treat almost any pain. But morphine should not be used to treat biliary colic. So this is very important to remember. Now if you see, suppose this is our GIT. This is esophagus, stomach, duodenum. This is liver. In the liver we have gallbladder hai, and the bile duct will drain into the duodenum. So in biliary colic, the problem is there is stone in the bile duct, and this stone is irritating the bile duct, that lead to spasm of the bile duct which causes pain. Now, apart from the spasm of bile duct, the contraction of bile duct will help in drainage of the bile into the duodenum. Now, when we give morphine, it stops this pain also. It stops this pain, but in addition, what morphine does is it causes spasm of this sphincter. The sphincter present here is sphincter of OD. So morphine cause spasm of sphincter of Oddi. So what happens is bile duct keep on contracting, but the bile cannot be drained because already spasm is there. So when bile cannot be drained, so that will increase intrabiliary pressure. And when intrabiliary pressure increases, there is a risk of rupture of bile duct. So we will not like to take that risk, because if the bile duct ruptures, then we need to do surgical treatment. So morphine or opioids, they are avoided in patient with biliary colic. Clear? So this is important about analgesia. Next, coming to C for constipation. Morphine can cause constipation, means it decreases GI motility. Then some drugs which are decreasing the GI motility but less addictive, they can be used for treatment of diarrhea. So some opioids are used in treatment of diarrhea. We will discuss later on. Next is respiratory depression. So morphine can cause respiratory depression. This is the main thing we are worried about. Respiratory depression is aggravated if a person is already having respiratory disease. So morphine is avoided in conditions like asthma and COPD. It can worsen the respiratory depression. Next is euphoria. Euphoria means feeling of well. So if a person takes the injection of morphine, person get euphoria, person enjoys. And if a person enjoys, the person will like to take the drug again. So any drug which causes euphoria is likely to be addictive. So is morphine. So morphine is one of the highly addictive drugs. And addictive drugs have two important properties. One is called as tolerance. Second is called as dependence. Tolerance means the same dose of morphine which was initially causing euphoria is not able to cause euphoria now when we use it for few days. Now the person increased the dose. So due to tolerance, the person will keep on increasing the dose. That is the problem with the addictive drugs. Now, very important MCQ asked is, tolerance can occur to all actions of morphine except. So you can remember that tolerance cannot occur to 3 C's. C for constipation, C for constriction of pupil, and C for convulsions. So 3 actions of morphine to which tolerance do not develop: constipation, meiosis or constriction of pupil, and convulsions. Tolerance do not develop to these 3 actions. Okay? Then second is dependence. And we discussed dependence may be psychological, it may be physical. Psychological dependence is characterized by craving. The person try to get the drug, but the person may not have withdrawal symptoms. But physical dependence, as the name tells, it is characterized by withdrawal symptoms. If the person do not get the drug, person will develop physical symptoms which are called withdrawal symptoms. And the withdrawal symptom with any addictive drug, they are of 2 types. First, the person was taking the drug since 6 months, 1 year, 5 years. When we suddenly stop, the body will feel the emergency. Body will think that there is some emergency, so sympathetic system will be activated. So the person will develop sympathetic symptoms, tachycardia, palpitation, tremors, hypertension. All the sympathetic symptom will be there. So it is common to every addictive drug. The second type of withdrawal symptom will be opposite to normal action of the drug. So whatever drug was doing, the withdrawal symptom will be opposite to that. Like morphine was causing sedation. So opposite will be stimulation of brain. The person may develop convulsions. Morphine is causing respiratory depression. The opposite will be tachypnea. Morphine is causing constipation. The reverse will be diarrhea. So opposite to normal action of opioids. Okay? So this is about the euphoria. Then lastly, meiosis. Morphine cause constriction of pupil, meiosis, and if overdose occur, it can result in pinpoint pupil. Remember, morphine poisoning is very important cause of pinpoint pupil. Clear? Now, one more important point regarding meiosis is morphine, the only absolute contraindication of morphine is head injury. The question is why morphine is contraindicated in head injury. The most important reason is morphine result in meiosis. The question is meiosis. Yes, the most important reason is meiosis. Basically, when the person has developed head injury, most of the time the person will be in comatose state. Now we are giving various medications, and now we want to check the progress, whether the person is improving or not, and that we are mainly assessing from the pupillary reactions. We see whether the pupil is contracting, responding to light, not all these things. Clear? So if we give morphine, it will cause meiosis. Always the pupil remain contracted, so we will not be able to assess the progress of the person. So when we are not able to assess the progress, we cannot treat the person. So that is the main problem. Assessment is not possible. Second, morphine cause respiratory depression. We know morphine cause respiratory depression, and a patient of head injury may already be in a respiratory depression. So morphine can aggravate that. And third, morphine can increase intracranial pressure. So basically, when it causes respiratory depression, the carbon dioxide will accumulate. That will cause vasodilation, which can result in increase in intracranial pressure. So because of these reasons, morphine is absolutely contraindicated in head injury patients. Okay. So these are the important points regarding the actions of mu receptors, that means saccharum. Okay.
Now the drugs acting on opioid receptors are classified into agonists, opioid agonists, opioid partial agonist, opioid agonist antagonist, and opioid antagonists. So these four type of drugs, first of all we will understand the meaning of this. We will say a drug is opioid agonist when it stimulates all the three receptors, that means mu, kappa as well as delta. We will say a drug is antagonist when it blocks all the three receptors, that is mu, kappa and delta. So when all three are stimulated, it is agonist. When all three are blocked, it is antagonist. Now partial agonist is a term mainly used when a drug is partial agonist at mu opioid receptor. If a drug is partial agonist at mu receptor, it is called partial agonist. Then agonist antagonist is a term used when a drug is agonist on one receptor and antagonist on some other receptors. Now most of the opioids which we have, which are agonist antagonist, they are agonist on kappa receptor and antagonist on mu receptor. So this is the classification of different opioids. So we'll start with the agonists. The major agonist morphine we have already discussed. Now apart from morphine, the other drugs in opioid agonist category include heroin, methadone, pethidine, then we have drugs like codeine, folcodeine, dextromethorphan, and noscapine. Another drug are loperamide group of drugs. Drugs like loperamide and diphenoxylate. Lastly, we have tramadol group of drug, tramadol and tapentadol. And apart from these, we have some opioids which are used in anesthesia. These are fentanyl type drugs. Fentanyl, L-fentanyl, sufentanil and remifentanil. These are the drugs. So we'll discuss the important points about opioid agonists one by one. Morphine we already covered in detail. Heroin, it is around 100 times more addictive than morphine. So it is not used in clinical practice. The only important clinical point is it is an addictive drug. Now methadone is a very long acting opioid. Its major clinical role is to used in de-addiction of opioids. Now pethidine, special point to remember about pethidine is most of the pethidine, it is metabolized by an enzyme called monoamine oxidase A. Pethidine is metabolized by MAO-A and it become inactive. So around 99% of pethidine become inactive with MAO-A. But very small amount of pethidine, you can say around 1%, it is converted to norpethidine. But the amount of norpethidine produced is so small that it do not cause any problem. So if we give pethidine for 1 day, very small norpethidine is produced, so no problem occur. But norpethidine has very important property that this is very long acting. That means once it is produced, it will keep on remaining in the body. So if we give pethidine for many days, so daily norpethidine will keep on producing. So it will keep on accumulating because of long duration. And if it reach the sufficient amount in the blood, it can result in seizures. It causes CNS stimulation, including seizures. So pethidine is never given for long periods because norpethidine will accumulate and it can result in convulsions. Second thing, if a person is taking MAO inhibitors, like person is having depression, person is taking MAO inhibitors and this person develop pain and we give pethidine to treat that pain. So now remember, pethidine cannot be metabolized by MAO-A. So now all pethidine will start producing norpethidine. So that means even a single dose can cause seizures. So pethidine is contraindicated in a person who is taking MAO inhibitors. So that is important about pethidine. The next group of opioids, which are codeine, folcodeine, dextromethorphan and noscapine, these are used as cough suppressants. And the term used for cough suppressants is antitussive drugs. So codeine-like drugs, they are used as antitussives. Cough suppressants, they inhibit the cough center of the brain. Cough suppressant. And the antitussive drugs are indicated in which type of cough? Yes, they are indicated in dry cough. So codeine-like drugs are used for dry cough. The next group of drugs are loperamide and diphenoxylate. These drugs decrease GI motility. So loperamide-like drugs are used for treatment of diarrhea. Loperamide-like drugs, they are used for treatment of diarrhea. Very important point to remember is these drugs are indicated only in non-infective diarrhea. So if a person is having diarrhea due to infection, then opioids are contraindicated. Opioids are contraindicated in infective diarrhea. Now why they are contraindicated? Suppose a person is having bacterial infection like E. coli or Shigella infection and we give loperamide to treat. So what will happen is loperamide will inhibit the GI motility. So the bacteria which is present in the GIT, normally it is going out along with the diarrheal stool. But as we have stopped the movement of GIT, so the bacteria is not able to go out. So when it is not able to go out, it will remain in the GIT. So now it penetrates the GIT mucosa and it can reach the cells. And if it penetrates further, it can reach the blood also. So simple diarrhea can become septicemia, which can infect almost any part of the body. So we do not like to produce this complication. So loperamide-like drugs are contraindicated in infective diarrhea.
One problem is anti-diarrheal drugs are easily available with the pharmacist. So any person go to the pharmacist and can ask for anti-diarrheal drugs. So there is a person who is addict. He know that morphine will not be easily available. So he go to pharmacist and says that I am having diarrhea, give me loperamide. So pharmacist gives him loperamide. So now this person is a smart person. So what he does? he take 10 tablet of loperamide, dissolve them in water, make an injection, and then inject the injection, and the person is enjoying. Remember, it is an opioid. So we want that the person should not addict them. So how to prevent this abuse? So to prevent this abuse, the market preparation of loperamide or diphenoxylate they are never available alone. They are always given in combination with atropine. You will not find loperamide or diphenoxylate alone in the market. It is always given with atropine. Very small dose is already added, but the amount of atropine which is added is subtherapeutic, very small dose. Hypothetically assuming, suppose 10 milligram atropine work, here we have added only 2 milligram atropine. So if a person take loperamide plus atropine tablet for diarrhea, what is the actual problem, particular indication for which this is indicated? So person takes it for diarrhea. Person is taking loperamide full dose and atropine very small dose. So what will be the effect of atropine? Nothing. So the person will get only loperamide, so its diarrhea will be treated without causing any problem. But same drug, if an addict comes, now this person will take 5-6 tablets, dissolve them. So when 5-6 tablets are taken, that means atropine will also be added. So when atropine tablets are added, that means it will become pharmacologically effective. So now the atropine will start producing adverse effects. So it will produce dryness, blurring of vision, urinary retention. So that means person will not get any euphoria, rather person will start developing side effects. So person will not like to addict. Okay? So atropine is added to opioids to decrease the abuse potential. Okay.
Now next group of drugs are tramadol and tapentadol. The special point about tramadol like drug are tramadol and tapentadol like drugs, apart from their analgesic action through mu, kappa and delta stimulation, they have additional mechanism to stop pain, and that additional mechanism is they increase serotonin in spinal cord. In spinal cord, serotonin act as analgesic. So they increase serotonin in the spinal cord that contribute to their analgesic potential. So this question is asked in a different format. The question asked is, when we give opioid antagonist, it will stop the analgesic action of opioids. The question asked is, which opioid, analgesic action of which opioid cannot be completely terminated by opioid antagonist? The answer to that is tramadol or tapentadol, because they have two mechanisms to cause analgesia. So opioid antagonist will only stop this mechanism, but the second mechanism continue. So its analgesic action cannot be completely antagonized by opioid antagonists. So this is about tramadol like drugs. Then last group of drugs, fentanyl group of drugs in opioid agonists. They are highly lipid soluble opioids and they are used in anesthesia. Fentanyl group of drugs are used in anesthesia. Some special points to remember: fentanyl group of drugs can cause post-operative muscle rigidity. Fentanyls can cause post-operative muscle rigidity. Read carefully in the questions. If they ask the question which drug cause post-operative muscle pain, then the answer is succinylcholine. But if they ask the question which cause post-operative muscle rigidity, then the answer is fentanyl group of drugs. Special point about some of these drugs: sufentanil, it is the most potent opioid. Sufentanil is most potent opioid, whereas remifentanil is shortest acting opioid. Remifentanil is shortest acting opioid, and the reason of shortest acting action again is like succinylcholine. It is also metabolized by pseudocholine esterase. So we discussed three important drugs metabolized by pseudocholine esterase. These include succinylcholine, esmolol, and remifentanil. Succinylcholine, esmolol, and remifentanil. So these are the important points regarding the first group of drugs acting on opioid receptors, that means opioid agonists. Now coming to second group of drugs acting on opioids receptors. This include partial agonist. Partial agonist. The main drug in this group is buprenorphine. It is a partial agonist at mu receptor. Now, why we developed a partial agonist? To answer this question, we need to understand one thing. We do not prefer opioids in mild to moderate pain. Why we are not preferring? Because opioids can cause respiratory depression. That is the major side effects we are worried about. So when we want to use opioid, the problem is they can cause respiratory depression. So we thought that if a drug is partial agonist at mu receptor, so it will not cause that much respiratory depression. So this is the idea behind making a partial agonist. So when partial agonist is given, respiratory depressant effect will not be that much, and that's why buprenorphine is a drug which is said to have a ceiling effect on respiratory depression. Ceiling effect on respiratory depression. The meaning of this is it can cause this much respiratory depression only. The ceiling is low. That means even if we increase the dose, respiratory depressant effect will not increase beyond this. So buprenorphine has ceiling effect. So theoretically, this is a very good thing, but practically it is of not much use, because when we give buprenorphine, it has partial agonist at mu receptor. So that means it will have ceiling effect on analgesic action also. So buprenorphine virtually becomes almost equal to low dose of morphine. So although theoretically it is very good action, but practically it is of no clinical significance. So just important thing to remember, buprenorphine is partial agonist. The next group of drugs which act on opioid receptors are agonist antagonists. These drugs are agonist on kappa receptors and antagonist on mu receptors. And these drugs you can remember as Punjab National Bank drugs, PNB, P for pentazocine, N for nalbuphine, and B for butorphanol. Pentazocine, nalbuphine, and butorphanol. These are agonist-antagonist drug at agonist at kappa and antagonist at mu receptors. And special point to remember about these drugs are that they can cause hallucinations as side effects. So which opioid can cause hallucinations? The answer are agonist-antagonists. Agonist-antagonists can cause hallucinations. So pentazocine, nalbuphine, and butorphanol. Now the last group of drugs acting on opioids is opioid antagonists. They are antagonists on all the opioid receptors. Two main drugs in this category are naloxone and naltrexone. Naloxone and naltrexone. These are the two main drugs. And important points regarding these two you can remember from the name itself. Naltrexone is a longer name than naloxone. So naltrexone is long acting, whereas naloxone is short acting. Second important difference again you can remember from the name. Naltrexone in the name contains O, so it can be given orally. But you will say that naloxone also contains O. But no, naloxone contains O twice. So that means one O will cancel the second O. So that means it cannot be given orally. So it is given by intravenous route. So naloxone is given intravenously, whereas naltrexone is given by oral route. So based on these properties, naloxone is given by IV route, So when a person comes with acute morphine poisoning or acute opioid poisoning, the drug of choice is naloxone. Acute opioid poisoning. It is so much effective drug that it will immediately reverse all the effects of opioids. Like a patient with acute opioid poisoning, it will come with the symptoms due to excessive opioid action. And we know action of opioids are remembered as saccharum. So that means this person will have severe sedation. That means person will be in comatose state. Person is having constipation. That means bowel sounds will be absent. Person will have severe respiratory depression. Person will be having meiosis, so severe meiosis that pupil look like pinpoint. So all these are features of acute opioid poisoning. So person comes in comatose state. We give him naloxone, and it is so much effective that within 1 minute the person will stand up as if nothing has happened earlier. So all the symptoms will be totally reversed within 1 minute. Now most of the time the opioid poisoning occur in addict patients because they are used to take these opioids, and sometimes they take overdose and they go into coma. So now when we give intravenous naloxone, all the symptoms are reversed, and now this person will try to escape from the hospital. If the person goes out of the hospital, after 10-15 minutes, the person will again go into coma. Reason? The naloxone is very short acting. So it is very important that number one, these patients should not be allowed to go out of the hospital. And number two, after giving naloxone, when the person gains consciousness, we should start naltrexone. The reason is naltrexone can be given orally and it is very long acting. So person will not go into coma again. So drug of choice for acute opioid poisoning is naloxone, but drug of choice for maintenance in case of opioid poisoning is naltrexone. So naloxone for acute poisoning and naltrexone for maintenance. The last thing in opioids to discuss is opioid de-addiction. If a person becomes dependent on opioids, how do we do the de-addiction? Now, like all the de-addiction programs, first of all, we will divide the patients depending upon how much dependent the person has become. So we will divide it into short-term addiction. If the person has started taking the opioids just a few months back, and second may be long-term addiction when the person is taking since many years. Now in short-term addiction, what we will do simply is we will stop giving the opioids. And when the person do not get the drug, what will happen? Yes, the person will develop the withdrawal symptoms. And what will be the withdrawal symptoms? Remember, withdrawal symptom for any addictive drug in general are of two types. One, the person is not getting the drug which the person was taking daily. When the person is not getting the drug, the body will feel emergency. So that will lead to activation of sympathetic symptom. Sympathetic system will be activated. So that will cause tachycardia, palpitation, hypertension. All these sympathetic symptoms will come. So this withdrawal symptom is common with every addictive drug. So whenever any addictive drug is stopped, the person will develop sympathetic symptoms. Now second type of withdrawal symptoms are drug dependent, but these will also depend upon the drug. That means person was taking one drug since many years or many months. Now when the person do not take the drug, the effect will be opposite to action of the drug. Opposite to normal action of the drug. Like in this case, opioids are producing action as saccharum. When we stop giving opioid, the effect will be opposite to saccharum. That means instead of sedation, the person will develop stimulation of brain. The person may also develop seizures. Instead of constipation, the person will develop diarrhea. Instead of respiratory depression, the person will develop tachypnea. Instead of meiosis, the person will develop mydriasis. So the symptom will be opposite to normal action of opioids. So what we will do now is, now we will treat whatever symptoms occur. Like to treat the sympathetic symptoms, we can give beta blockers or we can give clonidine to press the brakes. If a person develops diarrhea, we can give loperamide. If a person develops seizures, we can give benzodiazepines. So basically, we will treat the withdrawal symptoms. So what we will do, we will stop giving the addictive drug. Person develop withdrawal symptoms and we will treat those symptoms. And when the symptoms stop after few days, then we will stop giving these drugs and the person become de-addicted. But the real problem occurs in long-term addiction because here we cannot try stopping the addictive opioid. The reason if we stop the opioids, then the withdrawal symptom will be so severe that the person will not survive. There will be sympathetic symptoms only, but they will be so severe that the person may develop ventricular fibrillation. There will be seizures only, but they will be so severe that the person may develop status epilepticus. So because of those severe symptoms, we cannot try stopping the opioid. So instead of stopping the opioid, we will replace the opioid. So we will replace it with a less addictive opioid, and the drug which is used for replacement is methadone. Methadone. So methadone is commonly substituted with the addictive opioids. In some countries, buprenorphine is also substituted, but mostly it is methadone. So we will stop the addictive drug and we will give equivalent amount of methadone to that person. Now why we are giving methadone? It is also an opioid. The main advantage is it is a very long acting opioid, and long acting drugs produce number one, less euphoria, and number two, delayed euphoria. So when a person is not getting significant euphoria, we can decrease the dose of such opioids. If a drug is causing intense euphoria, we cannot decrease the dose of those opioids. So we will give methadone equivalent amount. Suppose hypothetically assuming the dose of methadone comes out to be 100 milligram. So we will start 100 milligram methadone, and now we will gradually keep on decreasing the methadone over every 2 weeks. So from 100, next week we will make it 80. Next week we will make it 60. Next 2 weeks make it 40, and gradually we will stop this also. So over a period of 2 to 3 months, we will stop giving methadone also. So now the person is not getting any opioid. The person has become de-addicted. But problem is when the person goes home, the person can develop addiction again. So we want that person should not develop addiction again. So we want to prevent the relapse. This is called as a relapse. So we want to prevent the relapse. If a person go into addiction again, all this will be a waste. So we want that person should not go into addiction again. So to prevent the relapse, we start naltrexone to this person. Now how naltrexone will work is, so this person has gone home and we tell his relatives to give him naltrexone daily. Now what is naltrexone? Naltrexone is opioid antagonist. How it is given? It is given orally, so it can be given at home. And what is the duration of action? It is very long. So that means if person has been given naltrexone in the morning, it will block mu, kappa and delta receptor throughout the day. So if this person goes at the home and goes to a party and take opioid, what will happen? Nothing will happen. Person will not develop euphoria. So if a person keep on taking opioid for 2, 3, 5, 7 days and the person do not get any euphoria, so person is unlikely to go into the relapse again. So the chances of relapse are very high initially after de-addiction. So after 2 to 3 months of giving naltrexone, we can stop this also, and now there is less likely that person will go into addiction again. So this is important, how to do the de-addiction. So now related to opioids, the last topic is alcohols. Two major alcohols we are going to discuss. One is called as ethyl alcohol, ethanol, which is commonly consumed alcohol. And second alcohol is methyl alcohol or methanol, which is commonly an adulterant. Alcohols, in the chemistry you must have studied, is alcohol is metabolized to form aldehyde, and aldehyde is metabolized to form acid. The first reaction in the body is done by an enzyme called as alcohol dehydrogenase. and second reaction is done in the body by aldehyde dehydrogenase. The fate of both ethyl and methyl alcohol is also same. That means ethyl alcohol is metabolized to form acetaldehyde, and methyl alcohol and acetaldehyde is metabolized to form acetic acid. Similarly, methyl alcohol is metabolized to form formaldehyde, which is metabolized to form formic acid. Now, first discussing with ethyl alcohol. Now, in the ethyl alcohol, ethanol or ethyl alcohol is the main substance which causes euphoria. So, the person enjoys after drinking because of ethyl alcohol. After some time, it is metabolized to form acetaldehyde. Acetaldehyde is metabolized to form acetic acid, and acetic acid is inactive, it do not cause any problem. So when a person drink alcohol, it only enjoys and then no problem occurs. But the real problem is acetaldehyde. Acetaldehyde will cause all the symptoms which we do not want. That means it will result in abdominal pain, blurring of vision, diarrhea, and all those symptoms which are unpleasant. So if normally aldehyde dehydrogenase is very fast working, so that means when we give ethyl alcohol, it produces acetaldehyde, and acetaldehyde is very quickly converted to acid, so virtually no acetaldehyde remains. But if a person drinks excessive alcohol, which saturate the aldehyde dehydrogenase enzyme, then acetaldehyde may accumulate and which will lead to these symptoms. But we can utilize this. If a person want to quit alcohol, person is psychologically dependent on alcohol, but person is not able to quit it. Person want to quit, but the person cannot quit. So what we can do is, we can give a drug which inhibit this enzyme, aldehyde dehydrogenase. Now when we inhibit the aldehyde dehydrogenase enzyme, the drug which inhibit this enzyme is called disulfiram. Remember, disulfiram is a drug which is aldehyde dehydrogenase inhibitor. So when we give disulfiram, aldehyde dehydrogenase is not working. So this person is trying to quit alcohol, but the person takes alcohol. If the person is given disulfiram and the person consumes alcohol, then acetaldehyde will be accumulated because it cannot be converted to acid. And when the acetaldehyde accumulate, person will develop the adverse effects. So before developing euphoria, the person will develop the adverse effects like abdominal pain, blurring of vision. So person will think 100 times next time before taking alcohol. So this is type of alcohol de-addiction therapy. It is known as alcohol aversion therapy. So person will avoid alcohol because the person know that I will develop a problem. So that is called alcohol aversion therapy. Now another important thing, many drugs can inhibit aldehyde dehydrogenase, although they are not used for de-addiction. They are used for some other purpose, but they are inhibiting this enzyme. So if a person consumes alcohol after taking such a drug, it will again develop same problem. So that is known as disulfiram-like reaction. So disulfiram-like reaction. So as the name tells, if a drug inhibit aldehyde dehydrogenase and the person consumes alcohol, person will develop same reaction which was caused by disulfiram. So all the drugs which cause disulfiram like reaction, the person should be instructed not to consume alcohol after that. And these drugs you can remember from the mnemonic cyclic GMP. Cyclic GMP, it stands for C for cephalosporins, some cephalosporins which we will cover in the antimicrobial portion, some cephalosporins, not all. Another C is chlorpropamide, which is an anti-diabetic drug. Then G is griseofulvin, which is an antifungal drug. M is metronidazole group of drugs, anti-amoebic drugs, metronidazole. And P is procarbazine, which is an anti-cancer drug. So these are the important drugs which can cause disulfiram-like reaction. So this is about the ethyl alcohol. Now coming to methyl alcohol. Methyl alcohol is metabolized to form formaldehyde, which is converted to formic acid. Now in this case, both formaldehyde and formic acid are very dangerous. They can damage the retina leading to blindness. So person can become blind in case of methanol poisoning. So the best thing here will be to inhibit the formation of formaldehyde as well as formic acid, and that can be done by inhibiting this enzyme. So we want that even formaldehyde should not form. So the drug which inhibits the alcohol dehydrogenase can be used for methanol poisoning.
Previously, for inhibiting alcohol dehydrogenase, we were using ethanol. Ethanol, which is an ethyl alcohol. So the basic concept is ethyl alcohol and methyl alcohol are metabolized by same enzyme, alcohol dehydrogenase. So ethanol acts as a competitive inhibitor of methanol, alcohol dehydrogenase. So methanol will not be metabolized. But ethanol has two problems. One, it cannot be given IV. It is toxic when we give it intravenously. So ethanol, it is given by intragastric route. So basically we put the Ryle's tube, and through the Ryle's tube we will put the ethanol. So the problem is we are dependent upon GIT absorption. Because it is coming to GIT, it will be absorbed, come to blood, then action will come. And GIT absorption is not reliable. So we cannot exactly titrate the effect with the dose. That is a big problem. And second problem is it is an alcohol. So it will produce inebriant effect. Person will lose his senses, alcoholic effects will come, the person get inebriated. So to avoid these two problems, we developed a newer drug which is again alcohol dehydrogenase inhibitor, competitive inhibitor of alcohol dehydrogenase, but it is not alcohol itself. So that drug is 4-methyl-pyrazole. 4-methyl-pyrazole, or in short it is also known as fomepizole. Fomepizole, the name says FO means 4, ME means methyl, and pizole is pyrazole. 4-methyl-pyrazole. It can be given IV also, and it is not inebriant. So because of these actions, fomepizole is now the drug of choice for methanol poisoning. Fomepizole is now the drug of choice for methanol poisoning. Clear? Now another thing we can use in methanol poisoning is, we know that the formaldehyde which is produced, this can cause damage to the eye. It can damage retina, it can cause blindness. Formic acid and this formaldehyde, both of them can cause blindness. So we have inhibited alcohol dehydrogenase so that more formaldehyde or formic acid is not produced. But what about the compounds which have already been produced? So we will want that their metabolism should immediately occur. So when they are metabolized, the risk of toxicity will decrease. And the metabolism of formaldehyde and formic acid is dependent upon folic acid. So another thing we do is we give folic acid. It increases the metabolism of these compounds so that already present are metabolized and new formation decreases. Clear? So folic acid is also given, and fomepizole is also given for methanol poisoning. Okay. Another alcohol we have is ethylene glycol. It is used as antifreeze or lubricant in the industry. Ethylene glycol act like alcohol. That means like alcohols, it will be metabolized to form aldehyde. The aldehyde formed is called as glycol aldehyde. The enzyme is again alcohol dehydrogenase. Glycol aldehyde is converted to acid. So that is glycolic acid. This glycolic acid is metabolized to form oxalic acid. Now mostly this is the question of medicine. They ask the question, a person has consumed some industrial solvent, and after that the person comes with metabolic acidosis. Remember, it is producing the acid, so which can result in acidosis. Metabolic acidosis is there. Plus the person has oxalate crystals in the urine. So if there is metabolic acidosis with oxalate crystals in the urine, it points toward the ethylene glycol poisoning. So ethylene glycol poisoning, two main features, metabolic acidosis and oxalate crystals in the urine. So again, how to treat? For treatment, we need to inhibit this enzyme, alcohol dehydrogenase, and the drug of choice to inhibit alcohol dehydrogenase, yes, it is fomepizole. So fomepizole is a drug of choice for ethylene glycol poisoning also. For methanol poisoning as well as ethylene glycol poisoning, fomepizole is a drug of choice. Okay. Now we will move to alcohol de-addiction. Now for de-addiction purpose, we have three methods. First is replacement therapy. Just like in the opioids, we discussed that if we suddenly stop, there will be severe withdrawal symptoms. So we want to prevent withdrawal symptoms, so we need to replace it with some drug, maintenance purpose. Okay? Second thing, we can give some drugs which decrease the craving. Drugs decreasing the craving of alcohol we can give. And the third important thing we can do is we can give alcohol aversion therapy. So we'll discuss these one by one, starting with the replacement. The basic concept is we need to replace the addictive drug with the same drug, similar type of drugs, but which is long acting. We know alcohol is a CNS depressant. So we need to give another CNS depressant, but which is long acting. So that is benzodiazepines. So in replacement purpose, we will use a long acting benzodiazepine. So most commonly we use is chlordiazepoxide, or we can also use diazepam. So the single preferred answer should be chlordiazepoxide. It is used in alcohol withdrawal, or we can say for maintenance therapy or replacement therapy in alcohol addiction. Okay? So we will give chlordiazepoxide, gradually decrease the dose, and then we will stop. Now second, which drugs can decrease alcohol craving? Which drugs can decrease alcohol craving? So you can remember them as none of the above. Remember, no drug can decrease alcohol craving. So to remember, we have none of the above. So N for naltrexone, O for ondansetron, T for topiramate, and A for acamprosate. But be very careful. Naltrexone, it is used to decrease alcohol craving, but naltrexone cannot decrease opioid craving. Remember, it is an opioid antagonist. So when we give naltrexone, it will rather precipitate the withdrawal symptom. It will not decrease craving. So read carefully. Naltrexone decrease alcohol craving. But when we use it in opioids, as we discussed earlier, it can be used to decrease relapse in opioids. In alcohol craving, it decreases the craving, but in opioids, it decreases the risk of relapse. Clear? So this is the second group of drugs we can decrease craving. Then lastly, we have alcohol aversion therapy. Now, before going to aversion therapy, we will discuss some basic thing that alcohol like ethanol, it is metabolized to form acetaldehyde, which is metabolized to form acetic acid. First reaction is with alcohol dehydrogenase, second is with aldehyde dehydrogenase. So this we have already covered. The major euphoric effect of alcohol is caused by ethanol. But after some time, it is metabolized to form aldehyde, which is metabolized to form acid. And this acid is inactive. It will not cause any problem. So normally, when we take alcohol, we just get euphoria, we enjoy, and then the drug become inactive, no problem occurs. But the real culprit is acetaldehyde. If this accumulate, it will cause all unwanted problems. So vomiting, headache, blurring of vision, whatever problem is occurring, labile blood pressure, that is because of aldehyde. But aldehyde is normally not available because all the aldehyde is very quickly metabolized by aldehyde dehydrogenase to form acid. So if aldehyde dehydrogenase do not work, if aldehyde dehydrogenase do not work, then aldehyde will accumulate and then the person will develop a problem. Clear? And the drug inhibiting aldehyde dehydrogenase, as we discussed earlier, is yes, disulfiram. So disulfiram, it inhibit aldehyde dehydrogenase. So we can use disulfiram for alcohol de-addiction. So basically what we will try to understand one important thing. We have a friend who drinks a lot of alcohol, but every morning he says, "Aaj se band, I will not drink from today." But again in the evening he is drunk. Yeah? So what we do, we ask this person, "You want to quit alcohol?" He said, "Yes, I want to quit alcohol. I will not take from today." So what we do, we say, "Take disulfiram." Now we give him a tablet of disulfiram. So when disulfiram is given, it inhibited aldehyde dehydrogenase. Now in the evening, this person forget that what he has told in the morning. So now the person drinks alcohol. If the person drinks alcohol, alcohol will be converted to aldehyde because alcohol dehydrogenase is working. But aldehyde cannot be converted to acid. So that means aldehyde will accumulate. And when the aldehyde accumulate, this person will develop vomiting, blood vision, hypotension, and many problems will occur. So the next time the person will think 100 times before taking alcohol. So that is known as alcohol aversion therapy. Remember, disulfiram do not decrease craving, but the person do not drink alcohol because the person is afraid that I may develop same problem as last day. Yeah? So the person do not drink alcohol because of fear. So that is known as alcohol aversion therapy. Okay. But important thing to remember, there are two type of dependence. One is called as psychological dependence. Second is called as physical dependence. So we know psychological dependence means person has craving and the person is psychologically dependent that I cannot live without alcohol. But if the person do not get alcohol, there may not be physical symptoms. On the other hand, in physical dependence, the person is physically dependent means if the person do not get the alcohol, person develop the physical symptoms which are called withdrawal symptoms. Okay? Now disulfiram, it is indicated only in psychologically dependent patients. It is contraindicated in physically dependent person. The reason being, if we give disulfiram in physically dependent person, what will happen? If the person drink alcohol, the person will develop disulfiram like reaction. So all those problems will occur. And if the person do not drink alcohol, person will develop withdrawal symptoms. So in both the cases, the person is developing some problem. Okay? So it is not indicated in physical dependence, but it is indicated in psychologically dependent people, because if the person drink alcohol, only then the problem will come. If a person do not drink alcohol, no problem occur because there is no physical dependence. Clear? So disulfiram is indicated only in psychologically dependent patients. Okay. So these are the important points regarding the alcohol de-addiction. So that means we have completed the addictive drugs like opioids and alcohols. Okay.